I'm working in Rwanda. I'm part of this organization called African Center for Research on Wonderful Care. It's a non-profit organization based in Kigali. I think our major focus now is to do research on palliative care, end-of-life care. I'm going just to share with you some of our experiences. So my role today, I would like to just share what I'm thinking could be great for choosing wisely, especially in palliative care. I would like just to remind you something really important. There is two different concepts between treating the disease and treating the person. You can treat the disease without treating the person. But if you treat the person, you can treat the disease as well. My understanding is two different concepts, because sometimes people are so focused on treating the disease and generally forget to treat the person. But if you treat the person, there is key element, and that is really important to add in your management. And that's, for me, it's the most important thing. So when I was doing palliative care in Rwanda, I came to, one of my questions was why physicians, nurses, and most of healthcare professionals, they are fear to talk about death, especially one of the colleagues said most of patients and cancer came on stage 3 and 4. And I need to realize that I need to do some research. And I'm going just to share some themes came up from my research when I was doing my master's program in US. First, to understand why people are still fearing talking about death, especially our patients. Most of our patients need palliative care. And the historic context is really important. And I just realized from the research three main points. There is a historical shift in the meaning of death itself as influenced by the patient on end-of-life care. That is during the pre-colonial period in Rwanda. So we came out to realize that death was viewed as an achievement because it was considered part of the normal life and natural phenomenon. This article is already submitted, so we're waiting to be published. So it was reviewed as a natural reprieve and the reward as a well-lived and fulfilled life. And it was reward to be a spirit. So in Rwanda, before the pre-colonial period, when someone was dying, it was really a privilege to the family to be there, because that person was preparing to be a spirit, an ancestor in our community. So it's why in Rwanda, when you introduce yourself, I mean, long time ago, people did introduce themselves like, my name is Christian Ntizimira. You introduce you from the name of your family, or the name of your father, or your grandfather, or your grandfather. And that was really important, because even someone died, but it is still living in the family. So it was really a privilege, because death was considered as an achievement. And for me, I think, choosing wisely, we need to bring the patient to those who came on end-of-life care or terminal illnesses to die, but their death has to become an achievement for the family and for the whole community. So the second point, it's about good death and bad death. And good death was viewed when the social cultural engagement and the family members and the community during the dying process. As I said, it was a privilege, not hardship. And that time, having children was the major criteria by which a person in the society was judged, because it was representing the high achievement. And that was defined by good death, because when someone was dying with alone in the family, in the society, and in the community, and that was considered as a bad death. Especially if you die without children, a wife, and the other family members. Why? Because that's time when someone was dying, or someone die, the family members has to put the dead body on the position on the fetus in the wounds. So that was the way people was judging that is the good or it's a bad death. So you can imagine before the process, the rigor mortis process, if the patient was or someone was dying alone, and the family or the community didn't put on that position, it could be seen bad at that time. So how death shifted to become a source of fear? One, it was the adoption of Christianity, the Christian belief in the colonial period. This shifted the paradigm of death to become a perception of end of life change completely. Because Rwanda at that time didn't have the concept of heaven and hell. So the concept of hell and heaven, which brought, the choice, was not familiar from the Rwandan tradition prior to the colonization. So death as a penalty and sanction increased fear and changed the perception of them during the dying process. So, and the ritual of ancestors changed completely to the ritual of evils, which is in our language, when you say abazimu, which is ancestors, and changed completely where ikuzimu was the place where ancestor was living, now become hell. That was really important on my research because now I can understand, instead of saying we need just to train people and then people will be able to understand palliative care, I just realized even the concept of death and dying is more deep based on our historical context, how historical has really affected the shift of the meaning of life and death, and that was really important. So it's why when I'm training people in Rwanda, when I'm training healthcare professionals, when I'm training students, I'm trying really to focus and say, please, you need to understand first your background. Historical context matters in medicine, and also using the medical anthropology, because that is really important. It's not only it's not only about prescription of morphine, access to treatment and education, and even about education, which kind of education are we talking about? So choosing wisely an African perspective, what we're trying to include in our program now is introducing the concept of Ubuntu in palliative care. Why? Because contrary to the Cartesian philosophy, I think, therefore I am, Ubuntu, it's more about I am because we are. It's humanity toward others. And what we would like to bring back, especially in palliative care, my colleague mentioned, because if I'm asking the definition of palliative care, people think that palliative care is end-of-life care, which is unfortunately affecting the whole management of the patient. And in Ubuntu, there is no disconnection between life and death, because death is part of life. So you are not you cannot disconnect death and life. And the perception or the meaning of life and death can change completely the management of the patient at a certain point. And Ubuntu values life, dignity, compassion, humaneness, harmony, and reconciliation. So why? And part of some of the experience we are doing, we just understand that Ubuntu is one of the best response to suffering, because patients in palliative care, they suffer physically, social, spiritual, and psychologically. And also to bring back the dignity of the patient, because when you have malaria and someone who has cancer, the discussion and the conversation in the society is totally different. And also, Ubuntu is a response to the social justice. What I said, patients versus disease. Are you treating the person, or are you focusing on the disease? Because the response on that will affect the management of the patient. Also, in the system of social protection, when you have a cancer, especially incurable disease, the way that you'll be treated by the society is changed completely. And what we're trying to do now is to bring back the engagement of the community for palliative care. Also, cost effectiveness to improve healthcare outcomes. This is something I discussed with my colleague from from US, when sometimes they ask, do you have a palliative care unit? Do you have a hospice? Do you have nursing home? I say, no, that is not be realistic in our context in Rwanda, because the system in Rwanda wants integration of palliative care in existing systems. So we're creating nursing homes and the hospices, that will not work who is going to pay for that? So we need something really realistic and contextualized in Rwanda society. And also the part of decolonization, because that's also something really important, because if we don't decolonize end-of-life care, we will still focus on the disease instead of focus on the person. Another point is about learning from our own mistakes. When I was finished my medical school, my dream was to be a surgeon until I met a very young guy, 24 years old, who was really dying on liver cancer. It was in Kibagabaga Hospital, one of the districts in Kigali City. So that time, I feared to prescribe morphine. The patient was in severe pain because there is a strong myth behind prescribing morphine. And I had the choice, either to move from my comfort zone and prescribe morphine to that patient and release pain, or I can keep that myth and continue to see that patient, dying in pain. Unfortunately, I chose to keep on my comfort zone, and I didn't prescribe morphine to the patient. And the second point is the sad story. His mom came to me and laid before me because he was really in pain to see, the son really crying, yelling in the ward, and no one can help him. So on my understanding, I failed twice. I failed as a physician because I couldn't prescribe morphine. I keep on my comfort zone. And also I failed as a Rwandan because in our culture, when you see elder person kneel before a young person, culturally you have failed. So I went back home and I asked myself, what the goal to be a physician if it just witnesses, people really dying? What the role to be? What is the goal to be a physician, or wear a white lab coat if just you passing and see patient dying and you do nothing? What is the aim to do medical, spend many years and do nothing for the patient? So I changed completely for my perception of to be a surgeon and become a palliative care physician. So the second mistake was, I have to be honest, is when I was training in the US, I was so happy to understand about the palliative care concept there, how they were doing. And I came back home trying to duplicate the same model I learned from the US. And I just realized that it was really impossible. And I was starting to conflict with my colleague and to the patient because I didn't understand the environment and the perception that time. And I just realized that to be educated doesn't necessarily mean to duplicate the same model, but rather that to adopt before to adapt. And that also is really important because if you want to adapt, if you want to duplicate a model you learn from one place to another place, that is not education. I think there is appropriate vocabulary for that. But I think if you say that you are well educated, so you need first to adopt. Why adopting? Because you need to understand the local perception. Then you'll be able to adapt according to the local challenges. And that is really important because it's not only about adaptation, it's about also adopting the local perception. Another point also from my mistake is to understanding about the patient's autonomy. I've learned that from US, and when the patient can decide who has to be part on board, the patient can decide everything. But in our context, it's totally different. Who pays the bills? Who feed the patient at the hospital? Who taking care of the patient? Is the family member. So instead of creating to disconnect again, because the patient is already disconnected by the disease, but instead of disconnecting the person to the community, I came back with this approach. I call it a butterfly approach, when in one side, I learn from the patient's autonomy, and then another side about the community responsibility. Patient autonomy does not exclude the community responsibility, as the community responsibility does not exclude the patient autonomy. We need to work on the both sides, because this is our reality in most of African countries, when you have the community engaged to support the patient. We cannot say, oh, we have a guidelines, we have the protocol about patient autonomy, that's it. No, that is not realistic. That means you are missing something in your management. Another critical point I understand for choosing wisely is in choosing wisely in palliative care, we need also to value expertise by experiences. And I explained to my colleague that I'm writing a book. This is one of the drafts, and I call it Safari. I think I don't need to explain what Safari means, because you understand very well than me. And it's a journey to understand the language of suffering for families, because that's also really important. When I was starting to sit with family members and trying to understand their suffering, and from the last 10 years, I did almost 800 family members meeting. And you can understand, I don't know the context in Tanzania, but in Rwanda, when you call a family meeting, it's almost between 20 and 40 people. They came and they want to be part of the meeting, and you need to manage them. You need to increase your communication skills. You cannot say, oh, I'm just working 1 or 2 people. No, because they are all connected to the patients. And at that time, I'm still using that concept for the meeting, and I came out with 12 animal archetypes, which represent 12 language of suffering, and in the way I can be able to manage, increasing first my communication skill, second to manage the group, because for the best of the patients, patient autonomy, community responsibility together. I'm going to give you just a few examples. What I'm calling the giraffe suffering. The giraffe suffering is a distance. It's the behavior when you have, during the family meeting, you see family members with unrealistic expectation and ignore the reality of local resources. Those are the most family members who live abroad in US, Canada, and Australia, come back at home and want to discuss. They want a CT scan, MRI at the district level, or sometimes oncologist, which is unfortunately we can't find, because that's also part of the suffering. So our interpretation is that the giraffe suffering express mistrust about their skills and the knowledge of the local team. So what we are doing now, our management, during the discussion, so it's difficult to go higher than a giraffe during the discussion, because they come with a high ego. And what we're using is mostly about confidence with humility during the discussion. This is the best answer. So the second example is about hyena suffering. It's a conflict. It's during the discussion you see people they didn't talk for a long time. You see father, they don't talk to the daughter, daughter to the brother, brother, they don't talk. There is a sort of a conflict, a long-term conflict between family members. And of course, which can impact in terms of care, dignity and empathy to the patient. So our interpretation, it's hyena suffering express a double antagonist feelings. So the patient, who is the source of conflict, but also it's also the source of connection. So people, they are really suffer to see that person is leaving, but also that person was the one who connecting all family members. So what we are doing, we never argue with the family members, and what we just try to protect the patient by identify who is the lion in the family, the most influential person. And the last example is about the torture suffering. This is the defense. It's most family members who came with more religious approach. There is a denier. And they think about miracles, philosophy, traditional healings, and there's a strong shield between your language as a physician and the language of family members. Our interpretation, torturers express a feeling of second chance, because they don't believe that their person is going to die, and is the one who providing some resources in the family, so it was difficult for them to discuss on some advanced care plan. So our management is language matters, and what I'm trying to encouraging to my team is when you get in a family, if it's a Muslim family, please, when you get in the room, you can say salam alaikum. Doesn't remove your doctors, your qualifications. If it's a Christian, you can say praise God, because this is come of the language they mostly use, and that can help you to create a good communication. So this is every animal archetype, any represent a suffering, represent a communication, but also represent also a solution. This is, for me, choosing wisely has to be adapted to the local communication skills you can develop using your language and using also your understandings. So part of my recommendation, just to conclude, one is the context, because the current model we're using in palliative care have grown out from the Euro-American clinical and culture experiences. So we need to adopt and adapt a very local context palliative care program. The second is the meaning. I just realized that the traditional palliative care in Rwanda existed before the modern palliative care. So if we need to connect in a global oncology community, we need first to connect our identities, and that is really important. And the last one is about culture, because international standard, when you're using a palliative care, can become also a source of social injustice by not taking account some elements which is really important and for the dignity and the humanity of the patient. So my conclusion, palliative care is choosing wisely, because palliative care is not optional, is not an extra, an add-on, a luxury, or an afterthought. It's an essential component of human cancer care. So to develop cancer treatment without parallel development of palliative care, it's a strong injustice to the millions of cancer patients around the world. And in every country, it's absolutely essential that when people talk about access to radiotherapy, cervical cancer screening, chemotherapy, all of it are important, they must also talking in equal measure and equal conviction about access to palliative care. So palliative also require a culture change because response to suffering is universal, but the method need to be culturally adapted and related. And also the last one is my favorite statement is the way people die can reflect how the society lives. So just want to thank my colleague Fidel and Maria and all the team from the invitation, and thank you. So if you have any question, please you can contact also me through any social media, but I'm happy just be able to share our experiences. Thank you.